Okay, sorry everybody. I was just trying to sort out what was going on from an admin point of view, but welcome to this evening's webinar, which is all about standing in the shoes of the CQC inspector and really looking through their eyes in your practice. So hopefully it will give you a really good insight into what they're looking for, and what to anticipate during an inspection. And I've done a little bit of research for you, and I pulled out some really sort of up-to-date key things that they're looking for. And I stand in CQC inspections with my clients every day. So I see hot off the, out of surgery, exactly what CQC are looking for and asking for. So I'm going to take you through all of that tonight. We've only got an hour, and I could talk to you about CQC for a whole day. It's a day course crammed into an hour. So what we're going to be asking you for is some feedback after this evening. If there's anything that you want to really drill down into in greater detail, like how to run audits, how to do risk assessments properly, patient feedback, getting team members engaged at a deeper level. There is so much that we can cover off. So please fill in the feedback form so we know what you want and we're not guessing at what we think you want or need. So I'd be very grateful if you can do that. So just a really brief introduction. I'm Nicki Rowland. I run a business called Practices Made Perfect, which is essentially a practice management compliance and management consultancy business. So I do in-house consultancy for compliance and lots of other things, and also team training. And I also do team training with teams on preparing for a CQC inspection, which is more important than ever before because your front of house team members have a very big role to play within the new single assessment framework. So I'm going to explore all of that with you. So without any further ado, I'm just going to share my screen with you and take you to the PowerPoint. Okay. So we're going to be looking at what to expect on your inspection day, discuss the practical application of CQC's guidance, particularly within the new single assessment framework, and also getting inside the mind of the inspector and what they're going to be looking for in your practice when they come in. So this is the best way really to view the new single assessment framework. And it's really a framework whereby providers are assessed to see that they are adhering to all CQC's regulations and the legislation that sits within that, the legal framework. So you can sort of look at this as a pyramid. And it is now a framework that is umbrellaing all health and social care. It's not just a framework for dentistry, one for ambulance services. It's for all of us. And it's to really streamline the process, make it a lot more simple for everybody. And it's not that one moment in time snapshot of your practice anymore. It's actually an ongoing process where they're going to be asking you to submit evidence and submit patient feedback, staff feedback, and there'll be regular conversations with providers and management teams as well. So within this triangle, let's just start at the top, because a lot of people are really fearful that the changes mean a lot of practical change. In actual fact, what you're doing on the shop floor has changed very little, if at all. You just need to continue doing what you're doing, operating in exactly the way you've been operating before to adhere to CQC's regulations. It is more that the narrative around the framework that has changed. So I'm going to take you through the wording, the phrases that you'll hear, the changes in phrasing that you will hear. So you're talking their language and you're keeping what you're doing aligned with their expectations as well. So at the top of the pyramid, we've got 5 key questions, and they're calling them domains as well. And these are the same 5 key questions that we had before. So what they're wanting to know is your practice safe, effective, caring, responsive, and well-led? So within those questions, we now have what CQC are calling quality statements. And those are the statements against which providers are going to be held to account. They have to provide evidence that sit within those quality statements. So what they're expressing them as is we statements. So what they're looking at is as a practice, you are saying, let's say, for example, we have rigorous and stringent safeguarding measures in our practice. When patients are interviewed, what they say reflects your we statement, and they're calling those I statements. So the patient would say, yes, I absolutely legitimately know what those safeguarding measures look like in that practice to know that I am safe and I'm being cared for in the right way in that practice, and that the whole team is trained. So I and we statements should be aligned. So we'll talk a little bit more about that moving forwards. One thing you don't have to worry about is you are given those quality statements by the CQC. All you have to do is to adhere to them and show evidence that you can meet that quality statement. As we move down the pyramid, the evidence that they're looking for becomes more specific. And they're looking at evidence in certain categories. So they're looking at people's experiences and feedback. So patients and what patients say is a huge part of what CQC is looking for. So building out those emotional patient journeys, your front of house team giving exceptional customer service, that is absolutely going to reflect in what your patients say. And there's so much evidence behind customer service. And actually, if you deliver a really top-notch customer service in your practice, then patients actually perceive their treatment outcomes to be better as well. So many reasons to actually really get that customer service and that whole patient journey really nailed down and make people feel absolutely cared for, because their feedback really falls into that caring key question. So again, your front of house team are really helping you tick massive boxes for caring. They're going to be looking for feedback from staff and leaders and the provider. So there will be maybe telephone interviews. There may be Zoom team interviews as well. They're going to be observing. So they are still going to be doing on-site inspections and observing you in your workplace. They're going to be very heavily looking at your processes. So when I talk about processes, I'm talking about the way that you do things. So they will, let's say, for example, look at your infection control and prevention processes and procedures. And what is written in that document needs to absolutely be reflected in what your team do day by day in your practice to ensure that your infection control and prevention is absolutely watertight. So if nothing else tonight, go back to your infection control procedures and ensure that they absolutely say what you do on the tin, and vice versa, that what your team does mirrors what is written in that document. In terms of your policies and procedures, they are deemed to be your team's instructions in the eyes of a CQC inspector. So if you were to induct a new member of staff to your practice, those documents are actually instructing that new team member. It's setting the standards, it's setting your expectations as to what that individual needs to learn, what they need to be inducted into doing, and then supported to achieve within their roles and responsibilities on their job description. Outcomes. Now, this is a really big thing. Outcomes are absolutely essential. And when I'm talking about outcomes, it is as a result of doing something, what is the result? So let's say you have a patient complaint. Let's use that as an example. Patient comes in, you have to go through a whole investigation as to what happened, and you've kept all your communications with that patient through the complaint process in chronological order. What was the outcome? CQC will ask to see your complaints folder. And if there isn't a clear outcome for that patient, i.e., what happened to them, do they still come and see you? Was the complaint resolved? Was there a good outcome for the practice? Was there a good outcome for the patient? Did you learn as a team from that situation? Did you use it as an opportunity for learning to ensure that your outcomes are good, that you're improving your processes to ensure that that complaint never happens again and that situation doesn't arise in the future? So outcomes need to be absolutely nailed down and written in black and white. And again, if you're running an audit, let's say infection prevention again, and you highlight areas for improvement in your procedures, have you actually then discussed it, used it as an opportunity for learning with your team, put an action plan together to ensure that you're filling those gaps or making those improvements, and then looking at the outcomes? So reviewing that audit again, maybe re-auditing within the next quarter to make sure that those outcomes have been nailed down, are absolutely rock solid in your practice, and have been maintained year by year. So those are the things that they're going to be looking for as evidence. And when we get to the bottom of the pyramid, this is where it's sector specific. So this is where they do really look at us as dental care professionals, what we're doing in a dental environment, whether that's a practice or community, whether you're a mobile dentist. Are you actually, during the process of doing your job, adhering to the regulations and showing evidence that sit within the quality statements? So that is it in a nutshell. Things haven't changed at all, really. They're just reframing everything to give us a framework for best practice standards and something that we can actually work towards. So what should you expect if you get that on-site visit? Well, it is a 2-week notice period. So please don't worry. You do have time to prepare. They're not going to come knocking on the door and catch you out. But I would also urge you, please be prepared. Have everything ready, because 2 weeks notice can mean that you can have a bank holiday in the mix. You might have Christmas in the mix, Easter. They're not, CQC are not worried about holidays. They expect you to be prepared and ready at any moment in time. So please don't leave it to the last moment. Intelligent and insight monitoring. Well, what does that mean? Again, phraseology that you might not have heard. Intelligent monitoring is where the CQC do their research on you. They look at your practice from the outside in. So they will look at previous CQC reports. They will look at Google reviews. They'll look at your website, your social media, any means by which they can actually extract information and start to build a picture in their minds about you. Insight monitoring is more of the information and evidence that they will ask you to send to them pre-inspection day. So they want to get an insight from you internally. So they might ask you to send your statement of purpose. They might ask you to send an audit. It'll be certain information that they want to see before they come on site. There will be still some remote inspections, but today I'm talking about what would happen during an on-site inspection. And normally it's 2 inspectors. I've actually been in inspections where 3 have turned up, but it's very much reflects the size of the practice. It's usually 2 inspectors. One of those inspectors will spend the majority of the day with the clinicians, looking at clinical records, talking to staff members. The other one will spend more time with the practice manager or your compliance lead, going through policies and procedures, going through risk assessments, audits, all that kind of evidence that you have. The inspections can be anywhere between 3 and 6 hours long. I've actually been in an inspection that was over 8 hours long. That can tell you that that practice was not well prepared. They literally called me in a couple of days before their inspection, hoping for me to magic everything better and to make sure everything was in as it should be. It can take weeks in some practices to actually get the evidence completely nailed down and relevant to what the inspector wants to see. So as I say, please be prepared. And the great thing is we're now looking at shorter inspection reports. So they used to be very, very wordy, extremely comprehensive. Reports now are literally more of a summary of what the CQC have seen, and they will help make recommendations. So this is not a punitive model anymore. It's very much a supportive model to help you aspire to achieve best practice standards. So please don't be worried. They are there to help, and they will. I mean, some of the reports that I've seen recently, the inspectors have actually flagged up pieces of legislation. They've actually directed the practice to a CQC mythbuster or information that will really, really help them to achieve the standard that they need to achieve. So, as I say, a very supportive model moving forwards, which I think is a breath of fresh air for all of us. So let's have a look at the practical application. They will go through your policies and procedures with a fine tooth comb. Please, please, please make sure that those policies and procedures have been reviewed within the last 12 months. And all your lead people, so safeguarding leads, infection control leads, your complaints manager, named people in documents are accurate. I was literally in a practice a few weeks ago, and they had their complaints procedure displayed to patients in the waiting area, which is a requirement, but it had the old complaints lead name on that document, and they'd left 6 months before. They had not reviewed that document. You need to be giving your patients accurate and relevant information. So if something does change in your practice, don't leave it 12 months to review that document. As I say, it absolutely needs to reflect how you're working in that moment in your practice. They are living documents, and as such should be reviewed in the moment if there has been a change within that area of work. So they will look at those in great detail. Risk assessments, we're going to talk about those, and audits a bit later on, and what are the obligatory ones that you need to be looking at. Patient feedback, there's a very, very much a huge focus on patient feedback, their experiences, and has your service met their needs from lots and lots of different angles, particularly the caring perspective. As I said, every patient is a human being, and as such, we should be treating them in that way and actually delivering our service to meet their individual requirements. That is really, really difficult in a fast-paced NHS practice. I know that. And I do want to be realistic, but they're still going to ask the patient's views. So it is important that you do go the extra mile. You do give patients the time that they need if they're nervous, that you do deal with complaints, any feedback in a really thorough and robust fashion. They will look at your physical resources. So your equipment, your premises, is it fit for purpose? Is it safe? Is equipment serviced, validated in the time periods that it should be? Have you got certification for it? Things like waste disposal, have you got all your waste consignment notes and your waste transfer notes stored in a chronological order so you can show evidence that the provider is doing what they are legally bound to do to be responsible for that clinical waste from its point of production to its point of destruction. So do you have all that information? They will be looking and doing a deep dive into the evidence that you're storing to show that you are doing the right thing. And then human resources. We're going to be talking a little bit more about recruitment, what CQC are looking for in terms of your staff and where they sit within the safe key question. So lots of things to talk about in a very short space of time this evening, as I said. So let's be the inspector. We're going to draw up in our car. The first thing they're going to do is have a look at your practice from the outside. So they're not going to instantly walk through the door. They are going to be starting their observations before they even put a foot over the threshold. So the first thing to look at is, and you can do this yourself, and I would urge you to do the process that I'm taking you through tonight. Go room by room by room through your business and actually look and make sure that you've got all the right things in place that we're discussing this evening. As I say, this is a whistle-stop tour. There is a lot of fine detail that they're looking for, but I'm going to try and pull out tonight the real focus areas, the things that are really relevant to them at the moment. And as I said, I've done some research for you and I've written it down, and I really want to highlight the new things that potentially you might be asked about at any point by the CQC. So hopefully we'll be covering off immediate issues that CQC are looking at. So staff plaques, your name plaques for your clinicians. Again, numerous times I go to practices, I will make a note who the clinicians are. I'll go into the practice and maybe one or two of those clinicians have left and their names are still on the website. So again, please make sure all that information is aligned and that your service providers are the ones are named and are the ones in your practice. One of the things that CQC want to see in your reception area is a list of GDC registrants with their name and their role, and those need to be displayed to patients. So there should be that consistency. So when the patient comes through the door, they can see who the clinicians are on the plaques. There's that list of GDC registrants in the reception, and all of that should be reflected on your website if you've got one as well. Opening times should be displayed. A lot of practices don't display their opening times because they'll say, oh, it's on the practice leaflet or it's on our website. But you're still going to have your older population who maybe don't have access to your website. They're not IT savvy. I mean, certainly I've got elderly relatives in my family who couldn't even accept my electronic wedding invitation because they don't use a computer. So you are still going to have those kind of patients who don't have those resources at their fingertips. So yes, having the written opening times somewhere visible is so patients can see it from the outside of the practice is something that I would highly recommend that you have. Your AED sign needs to be visible from outside the practice as well. So people walking by know that you've got an AED on site and you're actually physically telling your patients, yes, you do. You know, they're in safe hands if anything happens to them when they walk through the door. Clinical bins. If you store your clinical waste in bins outside, they'll be looking to see where they're located. They might go and try the lid. Is it opened? Is it locked? Is it secure? Is it a bin that might be locked, but could it be wheeled away by a member of the public? If it is somewhere that it's accessible, it ideally needs to be chained to an immovable object. So please go and look at those things and check the security of your clinical bins, because there's all sorts of things that people want to get access to in those clinical bins potentially. So do ensure they're as secure as they can. They'll also be looking at your security. Do you have bars on the window? Do you have shutters that come down? Have you got CCTV on your premises? If you do have CCTV, then and you're storing footage from that CCTV camera or cameras, then you need to have a CCTV policy and a written procedure in and around how long you keep that footage for, how you destroy it, how long you keep it for. Within GDPR guidelines, that footage is deemed to be personal data. So it needs to be handled in the correct way. So please do make sure you've got a CCTV policy if you have one. Again, accreditations, if you've achieved something like BDA Good Practice, or you've got an award or something that you can actually display externally, then put it on the door, put your plaque outside your practice, make a song and a dance about it. CQC want to see that you're going the extra mile, and so do your patients. Your patients want the best of the best, so tell them what you're achieving, get your plaques out there. And again, disabled access. If you've got curbs, if you've got written thresholds, do you have handles on the doors? Do you have a fixed ramp? If you don't have a fixed ramp, do you have a removable ramp? Is the doorbell at, or whatever means you have at the front door to alert you to the fact that a patient might be at the door, is it at the right user level, potentially for somebody in a wheelchair, as well as somebody who's fully fit and mobile? So it's looking at all of those things and ensuring that accessibility is as good as it can be as well. So let's walk through the door of your practice. And what are they looking for in the reception and your waiting area? Well, as I said, it's all about first impressions. So how are your patients greeted? What is that greeting? How do your front of house team member present themselves? So are they suited and booted? Are they sat there in scrubs? Is their customer service top notch? Or do they not look up when a patient walks through the door? I've had all sorts of experiences in practices where customer service has been pretty poor, to say the least. And again, just to let you know, guys, that is something that I deliver training on as well. So if it's something that you need help with, please let me know. And please also offer the CQC inspector a drink, some refreshments, a chair to sit down in whilst you're calling the practice manager or the practice owner down from the office. Make sure they're comfortable. They might have had a very long drive to get to you in busy traffic. So make them feel at home, make them feel welcome. Have a look at your notice board, your notice board for patients. There's many, many, many things that need to be on that notice board, and I'm just going to pull a few out that tend to be missing. So you need a GDC core standards poster, and that's on the website of the GDC, so print that off and get it displayed. As I said, names, job descriptions and GDC numbers of team members displayed. Your complaints handling notice with a named complaints manager who is still in the practice. Fire action notices, no smoking signs, simple price lists that reflect what you've got on your website as well. They need to mirror each other. If they don't, then we could be breaking the rules of GDC's advertising guidance. So everything needs to be aligned. Do you have advice and treatment leaflets in reception? They should be in reception, not in surgery, unless they are stored in a cupboard out of the remit of aerosol in the environment. Is there a means of your patient leaving feedback, instant feedback? So comments and suggestion boxes, do you have those? Obviously, if you're NHS, you need your friends and family test, but there also needs to be a means by which your private patients can leave feedback. So comments and suggestion box, or a lot of practices are going down the route of creating a QR code that can be scanned and patients can leave feedback directly to Google or other means. So yes, whatever fits best for you. And obviously when the CQC inspector leaves, it's lasting impressions. It's how do you leave them feeling? And they will be looking at how your team interact with patients through the inspection as well. And it may not seem obvious to you that inspectors observing, but they will be listening, they'll be tuning into those conversations, whether they're on the phone, whether it's face to face, and actually watching how you actually interact with patients on the day as well. So surgeries, let's walk into a surgery. How's it presented? Is it clean? Is it easily wipeable? Are the surfaces uncluttered? Or is there gear all over the place? I recently went into a practice and the work surfaces on the surgery worktops were so cluttered that there was dust accumulating because it was so cluttered that it could not be easily cleaned. That is not acceptable. Work surfaces need to be completely clear. Things need to be put away into cupboards, and it needs to be as minimalistic as possible to allow for thorough cleaning. The CQC inspector will want to see a surgery checklist. So not just for setting up and closing down, but for cleaning your surgeries as well. So please make sure you've got those checklists and you're using them every day to show evidence that you are doing the right things, you're following a protocol, but you're doing all the right things to keep your surgeries clean as well. And they literally will come do a finger test, and the top of the arm on your light, windowsills, skirting boards, you name it. They will be looking for any traces of dust, and your surgeries should be absolutely spotless. You should have an information folder in there. The days are gone where you have to have things like your local rules displayed on the wall, stuck next to your x-ray machine. Yes, you still do need to have a copy of your local rules in your surgeries, because they, again, are your team's instructions as to how to use that x-ray equipment in that environment. And it should also name your RPA, your radiation protection advisor, and your medical physics expert, who your external people, and your radiation protection supervisor, who's your internal go-to person if you've got any questions or issues in and around the use of your x-ray machines. In those information folders, you should also have an inoculation injury poster. Some inspectors like to see your safeguarding contact details in there. Obviously, the name of where to go if you do have an inoculation injury. You can put any other information in there, like price lists. So it's just key information that needs to be in there. And again, there's a lot to go through. So if you do want a list of what needs to be displayed in surgery, but also what you need to display in reception, please, please, please do let me know, and I can send those over to you. And I will leave you with my email at the end of the presentation. So if there's anything you need, any questions you want to ask, I'm happy to do that as well. Upholstery and flooring. Again, make sure that your floor, your upholstery is intact, that nothing's peeling away, that you don't have any cracks in flooring or upholstery. So it allows for absolute robust cleaning. Cleanliness, particularly since COVID, is top of the CQC's agenda. So things like domestic cleaning audits, again, should be something that you should do at least on an annual basis. And if you're using an external cleaning company, you may get them saying to you, well, we do our own audits, we audit what we're doing, but you need to audit the audit. We have got certain national standards for healthcare cleanliness that we need to adhere to. So we need to be checking that those people that we engage to do our cleaning are doing the right thing and adhering to that legislation. And again, just small things. They will look at how you're storing your mops as well, your color-coded mops. Now, for me, it's a personal thing. I really dislike mops because they just, in my mind, push dirt from A to B. Once they've been used, how can you be sure that they're absolutely spotless? How can you make sure that when they're drying, they are dry and they're not harboring bacteria? For me, a much more robust way of ensuring that your mops are clean are to buy, and I'm not suggesting this particular brand, but the kind of flash mops that are battery operated, that have got disposable strips at the bottom so you can clean a surgery floor, remove the strip, put a clean strip on to go into another surgery. And you can color code those as well. And then you don't have storing issues. You don't have to dry them. They can just go in a cupboard. You don't need a rack to hang them on. You don't need buckets. It just makes things so much more straightforward. So again, something to think about. Surgery drawers. All I can say with regards to surgery drawers is to ensure that anything that is going to go in a patient's mouth is covered, is as sterile as it possibly can be. So please have a look at things like impression trays, anything that comes in a box. Ideally, it needs to be left in a box until it's used. So it's covered, it's being kept as clean as possible. All your pouches, your sterilising pouches, should be stamped with an expiry date on it. If there isn't expiry dates on bags or there's open bags in a drawer, that will not stand up to scrutiny. So again, I would encourage you to do an audit of your surgery drawers, particularly your pouches, and make sure that there isn't any open pouches, they're all stamped, there's nothing out of date. If you're finding that standards are slipping and those things aren't happening, what you can then ask your team to do is to put a signature on those pouches when they stamp them, so you can then audit who is doing the right thing and who perhaps isn't doing what they should. So you've got that audit trail. And then zoning. Often what I see in surgeries is that the surgeries aren't zoned with dirty and clean areas. Some practices do have those words stuck on the wall, dirty and clean, but again, this is a personal thing. If I was a patient going into a surgery and seeing the word dirty, I would think, oh, part of this surgery is dirty, and I don't know how I would feel about that. So I prefer to recommend using coloured dots, perhaps green and red, so you know and your team know which area is which. And so long as that is written into your infection prevention and control procedures, then that is absolutely perfect and will actually tick the box that CQC is looking for. So let's move on to the decontamination area. So do you have a good flow of work from your dirty to clean area? And does your ventilation allow for that? So it's not clean air that's been drawn to the dirty area, it's the other way around. And have a look at your ventilation and make sure that it is actually meeting HTMO 105 criteria. We could talk about that for a very, very long time, but just reference that document. Again, is that room zoned? Do you know which are the dirty and clean areas? Is it clearly marked out so your team know as well? Processes and procedures we've talked about, so I don't really need to go over that again, but again, make sure your policies are reviewed every year. Validation, testing and logbooks. I see logbooks, let's say for autoclaves, I've seen this a few times, where those logbooks have been completed for the week. No word of a lie. It's a Tuesday and things have been filled in for the Friday. That would absolutely not stand up to scrutiny. Those logbooks are there to log things in the moment, what you're finding, what you're recording. So you've got that in the moment evidence. So please don't misuse logbooks. Make sure that your team know how to use them in the first instance and that they're logging the right thing. Make sure all the validations and testings are logged in the morning as well. Transportation of instruments. Yes, make sure your boxes are labelled. If you're colour coding your boxes, that is written into your procedures. And again, that your team are trained on your procedures in your decontamination area. And you're reviewing that on a regular basis so you know that everybody is doing the same thing. Everybody's sticking to those strict protocols. And particularly if the CQC come in, that your nurses are all doing the same thing. One thing I do see in decontamination areas is posters and notices all over the place. It's like a bus stop. There's blue tack all over. there's mixed messages because one poster says one thing, another document says another. You can buy posters that have got the whole decontamination flow on one poster. Have a look at your decontamination room. If you're one of those practices that's got pieces of paper and policies and things all over the place, simplify it. Make it simple for your team. Clean up that area. Make it practical, and just make your instructions as clear as they need to be. Things that, again, I still see. A few weeks ago in that practice I was talking about, I'm still seeing wire brushes. Please get rid of them. They've been obsolete and not accepted for quite a long time now. So long-handled plastic brushes, and as soon as your plastic brushes start to fray or the bristles start to splay, they need to be replaced, even if it's sooner than the recommended week. They need to be fit for purpose as well. In the office, this tends to be where all your compliance folders are, or if you've got digital compliance software where the main hub is for your compliance. So please make sure with a lot of the software that you can have now, it's a monthly cycle with a topic area behind it. It is so well laid out. A lot of these systems just literally handhold you through them. So again, if you're a practice that's still paper-based when it comes to compliance, if there is a better way of doing things and you want some advice in and around making your compliance digital and streamlining things, please just reach out to me. I can help you with that as well. Staff personnel files. Sometimes files only contain half the information that should be in there. There should be policies and procedures such as confidentiality policies in there, capability, disciplinary and grievance policies and procedures in there. Those are often missing. There's a whole long list alongside GDC registrations, indemnities, all sorts of things that should be in a staff personnel file. So again, rather than going through it in great detail, because we are flying through this hour, if anybody wants a list of what should be in those folders, please let me know. Evidence and certification. Lots and lots of certification in and around your decontamination equipment. Just for example, with your autoclaves, I'm just going to dig out my list so I can quickly tell you. I might have to come back to that at the end, but there is many things that you need to have for an autoclave. Oh, here we are. I just made my list. So for an autoclave, you need an annual service. Often within that service, an HTMO 105 validation has been conducted as well. That is a requirement. However, when I go in and do mock inspections in practices, often you'll get your service certificate, but it won't actually say that it's been had that HTM 105 validation done on the day, but it's often incorporated. So if you are one of those practices that you go to your annual servicing certificates and it isn't clear whether that validation's happened or not, please just go back to your servicing company and ask them to put that in black and white, whether it's a new certificate or in an email, just to show that you've got that evidence. You need pressure vessel inspections, written schemes of examination, and you need those two documents as well for your compressors. And it's roughly, with your written scheme of examination, it's roughly every year for your autoclave, roughly every 2 years for your compressors as well. And don't forget, your compressors need servicing every year as well. So your radiation protection folder, again, in many practices that I go into, this hasn't been reviewed within years. So the named people, the operators, are not accurate. Every detail in your radiation protection folder needs to reflect the personnel who are using the equipment. It needs to be absolutely up to date. And something that has come to light more recently is that if you use digital X-ray equipment, you need to have an inventory for that equipment, even down to the software that you're using for it, as you always have had to have for manual equipment. So please do make sure that you've got everything on an inventory for your X-ray equipment as well. Don't forget that you need to be registered with the HSE. You need that document of registration with HSE at your fingertips during an inspection as well. So please, please, please do make sure that you dig that out and make sure you registered it in the first instance. I'm still going into practices that have not registered. So please, please do. And clinical waste evidence, we talked about consignment notes and transfer notes. Have those stored chronologically as well. And within your policies and procedures, please have a look at your waste segregation, because as you've probably heard, we are now required to segregate waste into infectious and offensive waste. So we now need tiger bags to allow us to do that. And again, we don't have a lot of time tonight to answer questions on that. If you do want to know more about segregating waste, there's a brilliant CQC Mythbuster that I can direct you to, but also in HTM 01, the relevant HTM 01 document, it really will give you all the information that you need. So please do let me know if you need more information on segregation of waste as well. Toilets, who'd have thought? Disabled toilets, go and have a look at disabled toilets. They need to be accessible to any wheelchair users or anybody who's not particularly ambulant and needs assistance. So look at handrails, look for a drop-down handrail if you haven't got one. The things that CQC have picked up on recently in inspections that I've been in are an alarm in the toilet. If a patient is in need or they have an emergency, how do they alert you as a team to tell you that they need you, that there's an emergency? So do you have an emergency red pull to set off an alarm so people know that that person needs assistance? Can the door be opened from the outside? So if you have somebody collapse in the patient toilet, can you open the door and get to them to administer emergency care, if that is the case? If you do have wheelchair users, is the space for the wheelchair? And is it suitable for manually impaired people as well? So are your taps, can you use the taps with your elbow if somebody isn't particularly dexterous and is manually impaired? Cleanliness, have a cleaning log for your patient toilet as well. Please do make sure that the levels of cleanliness are absolutely top-notch in the patient toilet, as well as all the other domestic areas. Ventilation, is it well ventilated? If you don't have a window, a lot of patient toilets don't have a window, is there another method by which to ventilate the toilet? So please go and have a look at that. And if it's a shared toilet with your staff, any sinks that your staff use, even in your kitchen, need a hand washing poster by them. So it may be that you need a hand washing poster in the patient toilet. And it's also a really great place to display information. So information about services, if there's domestic abuse, if anybody feels like they're being sexually harassed, you can put those kind of posters on the back of the toilet door. And again, it is things that CQC look for, that you are giving your patients information and you are looking after and safeguarding them in every possible way, should they need those services. Staff area. As I said, there's a long list of things that need to be displayed to your staff. So if you need that, things such as safeguarding flowcharts, sepsis poster, so they know what signs to look for. Is there a list of named people, the go-to people in the practice? Is there a freedom to speak up policy displayed in there? So alongside your whistleblowing policy, if you're an NHS practice, you are required to have a freedom to speak up policy. And if you haven't, you're thinking, where can I find one of those? Just go to the NHS website, put that search into a freedom to speak up policy, and it does give you a template for it. It also will give you a map of the UK, and it will actually name Freedom to Speak Up guardians. So you need to have a named Freedom to Speak Up guardian outside the practice. So if one of your team does not feel that they can talk to the management team about an issue internally, they've got that guardian, that Speak Up guardian external that they can go to. And it will, on that map, it will often give you a named person in even their mobile telephone number. So find out who that person is and put it into the policy and display that to your team if you have NHS provision in your practice. Again, do you have an area for your staff to change? Is there secure storage for their valuables? These are all things that CQC will look for. It's all about their welfare as well as the welfare of your patients. And do you do things to celebrate your team? You know, what's the culture like in your practice? Under the well-led key question, they're looking for all these things, you know, so do you celebrate birthdays? Do you have events? Do you have like internal little awards for your staff? All of those things, make sure that they are visible. Thank you cards that you might have received as a team. All of these things help to reflect the culture in your business, and they will tick a big box for the well-led key question. So staff interviews. Gosh, we're running out of time, so I'll try and get through this as quickly as I can. Policies and procedures. They want to know that staff know how to access those. They are their instructions. So if you've got a digital system, everybody should have a login to that system, whether they're a clinician, they're a part-timer, or whether a front of house team member, everybody needs access to those policies and procedures. Fire precautions. Since the Grenfell Tower disaster, fire safety is a massive focus as well. So the staff probably will be asked, what do you do if in the event of a fire? Where do you assemble? Who does what in the practice? Has everybody got a job, a part to play to ensure that your practice is clearing out all your patients and staff members as quickly as possible and taking them to a safe place? Assembly points, they don't like you to be too close to the premises. So if you've got a car park at the back, it may not be far enough away. Bear in mind, you've got pressure vessels, oxygen cylinders, things that can explode on your premises. You need to be far enough away from the business that if you have an explosion, everybody's safe. And again, have you got it written into your procedures that if, let's say, your practice is in a shopping area, how would you alert other shopkeepers, other owners of businesses that potentially you've got a fire on site, particularly if you do have a fire and you've had to call the fire brigade? How are you alerting other business to the fact and actually helping them to evacuate as well, so they're being kept safe? Audits, I'm going to take you to those in a minute. We haven't got time to talk through how to audit tonight, but we could do another webinar. I've got a webinar purely about how to do rigorous audits and what to look for. COSH, again, please make sure that your COSH is up to date and it's actually relevant, and it's got every COSH risk assessment has first aid measures written into those COSH risk assessments. Your COSH is there for a reason. So if somebody is exposed, whether that's a staff member or a patient, to a potentially hazardous substance, you know how to administer first aid measures immediately. So for me, COSH is better kept in a hard copy folder. So in a chronological, alphabetical order. So if you do have, let's say, acid etch that somebody's been exposed to, you can go straight to that risk assessment, pull it out. You've got first aid measures on there, so you know how to administer first aid. Should that casualty need to go to A&E afterwards, you can then send them with that risk assessment and safety data sheet, and then the A&E team know exactly how to pick up with that patient's care because they already know the interventions that have been administered. So please make sure they're accurate and relevant, and first aid measures are very clear on there. Patient feedback. Please do a patient satisfaction survey every year, have that comment suggestions box and a QR code and/or. Quality assurance. What they're looking for is that you're driving continuous improvement in your practice. So off the back, let's say off the back of an audit, are you making improvements? Are you looking at it as a team to actually fill gaps, look at where you can drive that continuous improvement and how you monitor that those improvements are being maintained year after year after year as well. So you've got that evidence for quality assurance. Is everybody's CPD up to date? And has everybody got a personal development plan? They will ask your team that. Are they appraised on an annual basis? Another question is around mental capacity. So I've heard this asked many, many times. If you have a patient with a mental capacity issue on a day that they're coming in to the practice, and you, particularly if it's for treatment, how can you assess that it's in that patient's best interest to continue with their treatment if you feel they're mentally impaired in some way? So the answer to this really is you do a mental capacity assessment. And if you do have digital compliance software, many of the systems have a mental capacity assessment that you can print off and use, and it will help you funnel your yes and no answers on the flowchart to a decision, so you know you've done everything you can to help make a decision about whether to proceed with that treatment on that day or not. Duty of candor, it's regulation 20, so we're still adhering to legally binding regulations. Duty of candor is regulation 20. All your team need to understand what that is. And essentially, if something goes wrong in the practice, or you have a complaint from a patient, please offer an apology. It's about offering an apology. That is not accepting liability. It's just saying we're really, really sorry that something has happened, and we'll do our very best to make sure and endeavour that this doesn't ever happen again. So duty of candor, train your team on that. Gillick competence. They want to know that all your team knows what Gillick competence is. So have a look at that, train your team on that, refresh their memories. Do you have rigorous referral pathways so you can actually monitor the referrals that you're making, and that that patient has actually made it to the appointment that you've referred them for, and that they've been sent back to you? Have a record of all those referrals, every step of the way, what's happening, so you have that full view, that evidence of what has happened to that patient, and that they've received the care that you've referred them for. And I've talked about speak up policies and whistleblowing at the bottom. Risk assessments, you might want to take a quick shot on your phone of this list. I'm happy to share this PowerPoint if anybody wants it. So the one that I tend to see missing on the risk assessments is your business impact analysis. And this is actually your precursor to helping you to write your business, your disaster planning and contingency plans for your practice. So please, please, please make sure you're doing that in and around doing all the others which are listed there. These are your obligatory audits. Things keep changing, time intervals keep changing, but your biannual ones at the moment are your infection prevention and your radiograph quality. The others on there, you do need to be doing clinical records audits, and now not necessarily obligatory, they're recommended audits. And I think some practices have taken that as not having to do them, but CQC will look at your clinical records in great detail. So please, please, please ensure that they're robust and they would stand up to the scrutiny of the CQC and the GDC should they ever be used in a complaint situation. If you do conscious sedation, you need to be auditing your conscious sedation protocols and procedures. And if you prescribe antimicrobial drugs, you need to be doing an audit of your prescription drugs, particularly antimicrobial ones as well. So that is the end of my presentation. We're a minute over, but I want really to have a little bit of time, if we can, to answer questions. So if you've got any questions, what I'm going to ask you to do is to put them into the chat box. I'm going to stop my share of the presentation and come out of that so I can actually see the chat box. So as I said, it was a quick whistle-stop tour tonight. I could talk to you all day about CQC. So if there's anything that you would like more of, then please, please, please do let us know. Fill in that feedback form. Also, as part of the Female Dentist, you're going to get education, webinars like this, as well as all the amazing networking events. There's so much benefit to you joining the Female Dentist, and it's only £49.50 a year per annum. So if you've got any female clinicians, dentists, hygiene therapists who you think may want to join the Female Dentist, please do. It's a minimal cost. It isn't a subscription model, and there's so much value to joining as well. So a few questions now. Don't forget, if you use contract cleaners, you will need their cost sheets and assessments. Thank you for that, Ian. Yes, you absolutely will. Any product that is potentially hazardous to health needs to have a COSH risk assessment. So if you've got external companies coming in, they need to be COSH risk assessing the products that they're using. So please make sure that they have those. Okay, another great one from Ian. Thank you for that. A CQC inspector who was in a wheelchair. So just a heads up. So anticipate that and try and think in and around your disability access audit and accessibility for anybody who's, you know, a wheelchair user as well. Another one here is completing DSP toolkit mandatory for private practices. No, it's not, but it's a very, very good question. If you're a private practice, but you use an NHS email, then you do need to complete the DSP toolkit. Yes, you do. But other than that, no, it's not mandatory for you. So I hope that answers that question. Okay, anybody else? Anybody else got any questions in that? If we use Rego, not NHS email. No, if it's Rego, that's fine. And it's not an NHS email, you don't need to do the DSP toolkit. And again, if anybody's struggling with the DSP toolkit, it is a whole different language. So if you do need any support with a DSP toolkit, give me a shout as well. I can help you with those. Or registration processes, anything related to the CQC, mock inspections, compliance setups, please do let me know if you need any help. Right, any more questions here? Molly, we have safeguarding contact numbers pinned up on our staff room notice board. Is this sufficient, or should we put it in the surgeries as well? Molly, I would always be belt and braces. Leave it in the staff room, but if you've got a surgery folder with information in it, why not just put another copy in there and just cover both bases? Just make sure that whatever you're using, it has exactly the same details on those documents. Ian, again, thank you. Ian's putting, if you have a hearing induction loop, ensure it's plugged in. They will check. So yes, it's an anticipatory requirement for anybody who's hard of hearing for you to have an hearing induction loop. So again, as part of your disability access audit, please do ensure that you've got a hearing induction loop on reception as well. Okay, any more questions, anybody? Anything that I've missed, Caesar? Emergency drugs, guys. I haven't had much time to talk about those, but please make sure your emergency drugs are audited every week. You're checking your oxygen is working, that the pressure is as it should be, and that your AED is working as well. They will look at all those logs, water logs for Legionella. We can go on and on and on. So please let me know any further help that you might need. And this is your last chance to ask any final questions. So if you'd like to drop anything into the answers and questions or put anything into the chat, please do. Ian, no, I didn't have time to cover PEEPs tonight. There's so much that needs to be covered. So I do think it would be a good idea to do a second webinar if anybody wants to rejoin me, so I can actually cover off the finer detail. It was pretty much an overview. And as I say, I've got reams and reams and reams of things I can update you on here. But PEEPs are like a personal emergency plan for patients. So do you have those? So if you do have a wheelchair user who or somebody who has a disability, do you have a personal plan for them? If there is an emergency like a fire, to actually safely get them out of the business. So that's just an example of what it covers, but we could do some more detailed examples of things like that as well. So thank you for that, Ian. Lots of great feedback and information. Thank you. Caesar, I can't see any other questions coming in. Do you want to wait a little bit longer?
Hi, Nicki. I think that's it. Those were all the questions.
Okay, that's lovely. Yep, as I say, please do come and join us at